Well, friends, welcome to today's webinar. And this is the first session of the CBME Pharmacology webinar series. I'm grateful to Dr. Shantanu, Dr. Nirmala Rege, Dr. Gurudas Khilani, Dr. Princy Palati, who have agreed to become the resource persons, and all the participants who have joined in this group. As we start any session, we will start with the Saraswati Vandana with a invocation to Almighty that this series, the objectives of this series are achieved. With this invocation to the universal intelligence, we start this course, and we have started this similar courses in similar series in pathology, pharmacology, and microbiology, so that there is some kind of integration between the three subjects of second professional, and from time to time we will be making the three subjects interact with each other, so that some kind of integration takes place. I now invite Dr. Shantanu Tripathi to say the inaugural words. Over to you, sir.
Thank you very much, Professor Bedi, for the kind introduction, and I most heartily welcome all our colleagues from different parts of the country and our esteemed members of the faculty, and most importantly Professor Bedi, who has been the driving force behind this initiative. And it is so much needed for all of us who are engaged as teachers in different institutions. It's a great challenge to us delivering this new curriculum, teaching the subject of pharmacology to undergraduate medical students, and the challenge before us is delivery of the new curriculum as proposed by the Medical Council of India. We all know that this batch is the first batch to us. They have already completed their 1 year, the first professional, and now they are in the second professional. So all the second professional disciplines, including ours, that is pharmacology, it's our duty now to get ourselves prepared to deliver the curriculum. And when we do that, it has to be done in the most acceptable form of integration, not in isolation, not in silos, and keeping the broad objective in mind, the broad curricular objective. Always we need to remind ourselves, yes, there are subject specific or discipline specific objectives also, and we all know by now that it's a competency based curriculum. So most of us, I suppose, we have some kind of orientation towards what this or does all this mean, this competency based curriculum. But then some of us who have some confusion or have not been exposed to the principles to the extent that is desired. I hope and trust that this program, this is a 3-month program we have planned. This will give us ample opportunity to clear our confusion and to have a greater degree of clarity and what is actually meant by competency-based curriculum and what is expected out of us while delivering this curriculum to our undergraduate students. Yes, there is a lot of expectation from us regarding the so-called integration. And what does that mean also? What kind of integration we are looking forward and how best that can be done? Yes, there are a lot of limitations, but then under the current situations of all sorts of limitations, how best we can deliver. Okay, and whatever we do, and one of the very purpose of this platform or this program has also been to have a, to the extent possible, some kind of uniformity and some kind of harmony to be in place throughout the country. While having said that, we also would be respecting and welcoming the desired degree of flexibility to accommodate the local limitations and in resources or local requirements. So, but then the broad objective of delivering up to the standard and in order to finally come out with the product that is the MBBS graduate and the minimum set of skills that they are supposed to master, okay, broadly in order to become a basic doctor, good quality basic doctor. So keeping that in mind, we have a lot of expectations from the interactions that are going to take place in the coming 3 months. What we have primarily planned that there are 2 occasions every week we will be meeting, and Professor Bedi must have already informed us what would be the timeline or what would be the actual schedule, which of the days of the week that we'll be having this program, and more or less, I think everybody, all of us, particularly Professor Bedi, will also try to keep the timing of the meeting as much as possible fixed, so that we can also set that aside or get ourselves available in order to attend this meeting twice a week for that means it comes to 8 times a week, 8 times a month, and 12 times in that means 24 times in the whole of 3 months. So if it is 24 occasions that we are meeting, so practically speaking, it is 24 hours. So we cannot expect that we are here to actually learn or actually relearn, okay, the whole of the curriculum. That's or the content of the curriculum. That's not the purpose of this exercise. The purpose is actually how to deliver the curriculum, how best as teachers, how best we can deliver this curriculum. So the audience here are our colleagues, our fellow teachers, okay, and all of us are pharmacology teachers, and we are trying to learn from each other and develop a collective wisdom, so that at our own respective places we can actually do our best in order to deliver it in the most acceptable manner. And we, in this endeavor, in these coming 24 times that we'll be interacting with each other, we'll try to learn from each other through interaction, okay, and as much as possible this will be attempts will be made to make it interactive. Broadly speaking, it is an attempt to learn the methodology of delivery of the curriculum. In summarily, we are not there to actually deliberate on content of the curriculum. It is the process of the curriculum or the proposed process of the curriculum or methods of the curriculum delivery that we are interested in. So all discussions will be directed towards that, and we are fortunate to have amongst us, okay, people like Professor Nirmala Rege, a veteran teacher. He is known by her name throughout the country. We also have dedicated teacher like Professor Principalati, and we have very senior veteran teacher, Professor Gurdas Khildani, who always, all of these people, they have a passion in looking into this curriculum or looking into the undergraduate teaching. They love undergraduate teaching, all of us, and so I am sure they will try to put their best in making this very lively, very interactive. And of course, when we say this, it doesn't mean that people on the other side, okay, they are at the receiving end. All of us are actually trying to give the best from each other, and so that we can develop the collective wisdom when we leave this platform 3 weeks from now, 3 months from now. With these few words, I welcome Professor Nirmala Rege, madam, if you please come up and start with your presentation. So there will be two presentations, one after another. Professor Nirmala Rege, followed by Professor Principalati, and after that there will be an interactive session which will be moderated and coordinated by Professor Gurdas Kildani. And I am also there, always present in the background. With this, hand over to Professor Nirmala Rege, please. Thank you very much.
Thank you, Dr. Shantanu Tripathi, for setting the stage. Are my slides visible?
Yeah, it's visible.
Am I audible?
Yes, very clearly. Thank you very much.
Okay. I echo all the words what Professor Shantanu Tripathi mentioned. We are here as a group and we are supposed to interact. In the beginning, what I'm going to do, because we are a heterogeneous group, as he said, some of us we know some of us have attended CISP. They have started working on how they are going to transact it, and some of you are not so well versed. And therefore, what I'm going to do in initial 15 minutes, just run through the MCI curriculum as it is applicable to pharmacology. So all of you, if you visit this site of MCI, you will see this picture, which gives you an idea what is the competency-based undergraduate curriculum. Some of the words which are there, they will be coming repeatedly in MCI curriculum now. And why this has been decided that we have to have the change in curriculum, because naturally there is a need for wider clinical exposure right from the first MBBS. Our learning should be contextual learning. There should be more emphasis on the skills and attitude and communication. So far we were having lots of weightage on the knowledge and not on the soft skills. Also, one of the we are talking about it since many curricular revisions, that we have to make the students lifelong learners. But we need to have that some ways to do, and this curriculum may possibly provide us those ways. And of course, we have to comply with the WFME guidelines as well as the local needs. So when we looked at this reforms, this is not something for the first time it is happening. Already long back, you may be remembering that there was a Vision 2015 which didn't come to light that time, but that was based on the Graduate Medical Regulation 1997. That time the competency pattern was decided, and now it has been refined, taking into consideration we have defined the term competent Indian medical graduate and how that can make an impact on the healthcare. Along with that, there are lots of training is going on for the faculty, and that faculty development has started right in 2009. And that time also there was CISP. Now also it has been refined over a period, and ultimately it will be the backbone of the university and institutional curriculum. One has to remember that though there are certain changes has occurred in this 2018 amendment, the basic structure of 1997 framework is still there. There were many things were written in this graduate medical education 1997. Unfortunately, that didn't get transacted in our curriculum. But now it has become a gazette, this 2018, and we have to follow it. This definition, I'm sure those who have attended CISP, they know it quite well. We need Indian medical graduate possessing requisite knowledge, skills, attitude, values, responsiveness, so that he or she may function appropriately and effectively. The change which has been made from the previous one is the position of first contact of the community, and this community can be rural as well as urban while being globally relevant. So we are, that's why I said initially that we are also have to look at the WFME guidelines. The educational role of the learner in this curriculum is well defined, and as we are calling it as a competency-based curriculum, and I will tell you that it is not competency-based curriculum, but the student have to take the personal responsibility for learning. That doesn't mean the teacher should shrug away from their responsibility. It is joining hands with the students, and we have to be facilitator for them. But what we have to do is, and there is a time which is given for the self-directed learning methods. So there is a deliberate practice, and they should receive the feedback when they are making the progress throughout the curriculum. And that we have to keep this in mind when we are laying down that foundation for pharmacology. And secondly, we have to demonstrate and document the evidence of acquisition of competency, and we may have to use different methodologies for doing that. This particular curriculum, we have defined the goal. There are different roles have been defined, and 5 roles. And if you look at the competency, volume 1 of that your UG curriculum gives you the this competency document. And if you look at it, you will find that for each role, there are competencies which have been defined. Yet, the subject-based competencies are there, and we have not done away with the subject. So we are talking about the integration on one hand, but more and more emphasis has been given to the working in silos, and the competencies for the subjects have been defined. So if you look at the CBME definition and how the CBME curriculum is, people are conducting it in the worldwide, you will understand it is a hybrid, and it is not a traditional or the competency-based curriculum. You can call it competency-oriented curriculum. And this fact, we have to keep it in mind. So what is expected from us, because it was very, very difficult to do away with all these subjects and go suddenly into the integrated way. So it has been decided that we will go in a very cautious way, keeping the subject at this stage, but having their competencies with the hope that when we are trying to achieve the competencies in a subject, some of these competencies also can be getting linked or getting translated into the global role competencies, and ultimately the role competencies are matching with the global competencies. So there will not be a gap between the two, but we are at the beginner state, and we have to go very slowly depending on that. So now in this particular curriculum, there is a change in the structure. There is a change in the transaction. A lot of transaction guidance has been given compared to the earlier one, and there are certain new elements which are there. And there are both the mechanisms. There are facilitatory mechanisms and there are control mechanisms. So for us, the second MBBS stage, as you see over here, our students will be joining us in the month of October after passing the first professional examination, and they will be with us till August. That means we are getting this 11th month, and that last month of September 12th month will be for our second professional examination. That we have to keep it in mind. And in this phase 2, we will be having pathology, microbiology with us. Forensic medicine and toxicology is also with us during this period, but they will be having their exam with the phase 1, part one of the third MBBS. And of course, there will be clinical subjects will be introduced. The community medicine will be with us, and there will be all those EdCom module, which will be longitudinally run phenomena that will be with us. So 12 months and for the second professional. The change, as I said, that now the time span of the forensic medicine will be, the students will be appearing in phase 3, and therefore we may get little more time for these subjects. So the time allotted has changed from 1.5 years. We have now for 12 months. And time, we have to take into consideration whatever the time is allotted for the students for the self-directed learning when we are planning our timetable. Apart from these elements, because some of them, they are newly introduced and maybe starting in the first MBBS or after completion of the phase 1, phase 3 or part 1. But EdCom, as I said, will be running throughout. And these elements which were there in 1997, if you look at those regulations, there was integration was mentioned, horizontal and vertical, but our main crux will be on this integration and skill training. So there is a separate booklet on this attitude, ethics and communication, and you can get access to that, and that program must be in place in all the colleges now. What we have to consider now, as Dr. Tripathi mentioned, is our integration. Now, this horizontal integration has been mentioned as an alignment, and the vertical integration is called as the integration. In this particular, there is a document on alignment and integration. And what is expected for us, that in case of alignment, there is a temporal coordination. That means certain things which can be done with pathology and pharmacology simultaneously can be done in that particular department independently, but same topic may be taken in the pharmacology as well as pathology or microbiology. For example, if they are working on that microbial organisms, we can have our lectures simultaneously going on the antimicrobial. We have to work on this, and that is the most important thing we have to do, where we can develop this alignment. For the integration, it has been said, which will be in the vertical integration, it could be just sharing. So whatever that sharing can be with the same or same phase, or it could be vertical. So whatever we are doing in our area, we can share it with the other departments also, and they can develop the linkage. Or we can have certain things, majority part will be done by the individual department, but certain topics can be taken as the integrated manner, and that is called as correlation. So tuberculosis may be taught in pathology, microbiology, pharmacology, and medicine also, but there could be some integrated module on tuberculosis. And the nesting is done by the individual teachers in that department. So when you are transacting your curriculum, taking lecture or practical, you have to orient the students to the application or whatever will be done in that other subject, like medicine or surgery. If you are talking about the antimicrobial prophylaxis, you can think about the case and talk about that. That is called as nesting. So ultimately, our job is to cater to the needs of the learners, not to give to the integration. We should not leave it to their imagination, but we should provide them the opportunity to integrate the concepts. And it is said that it is just to give the learning experience of this integration to the students. So we have to retain our subject-based education and assessment. That has been the primary responsibility of the individual department, but we have to see that how we can provide them that experience, so that will help the learners to understand the basis or how they can apply those concepts, because sometimes the basis may not be very well understood when they are in that phase 1, but we can bring it through a nesting or through a case, and then we can show them how it can be applied. So the major method is the temporal coordination, and that's why I'm glad that these CBME discussions have started with pathology, microbiology, as well as pharmacology, because we can then decide that how we can do this alignment. Only 20% of the total curriculum, though you will find the number of examples have been given in the MCI document on UG volume 1. You need not have everything as that integration. There are just the suggestion. You have to think about that 20%, what you are going to develop as an integration, either through sharing or through correlation. And while, as I already said, while discussing a topic in a given subject, you can adopt the nesting. Today I have sent you a article by Harden, Dr. Harden, and that is on the integration ladder, and I request you kindly go through that So that will make the concept more clearer. So it has been said that information does not necessarily mean that you will require multiple teachers in each class. That is not the idea. So you involve the experts from the other phases and subject when you are planning the lesson. You can have the case-based discussion, but that is more important, bringing them the idea or giving them that perspective of the other subjects. And we have to ensure that that is our responsibility, primary responsibility, that the phase-based objectives are achieved, because unless we achieve the competencies in our subjects, we will not be able to integrate with the competencies in the role. So that we have to keep it in mind. Our assessment will be subject-based, but while having the assessment, we have to make ensure that at least the learner has got that concept of or the basis as well as its application integrated. And we have to also, when we will be discussing on assessment and planning it, we will have to take this into account. I think everyone is familiar by now with this type of, this is from volume 1. So the competencies are given, they have given the level of the competencies, which are the methodologies, and we will be discussing on that. Integration with which department, and they have given the choices. Again, I repeat, it is only 20% we have to select. We can do for more, that is good for us. And there is an emphasis on skill development in all the phases. So whenever we see the competencies as shows how or perform, then we have to remember this is either perform is either under supervision or independently. And that time we have to, there is a number which has been mentioned, that how many numbers they want us to perform. So that we have to see to it that those competencies which shows how and P, they will come in the practicals. And the skill labs may be in place with the various institutions, may be a individual department has some skill labs or elements of the skill labs, or there may be a skill lab for the institution. But that is mainly for the psychomotor, affective and communications domain. And that again we will see when we are talking about for the practicals, what are the competencies have been given. But no certifiable skills from pharmacology are there in that list of certifiable skills. But one has to remember the prescribing itself is considered by MCI as an essential skill. And it has been mentioned that some of the essential skills are mentioned right in the beginning of that volume 1. And their prescription writing is considered as an essential skill. So though it is not certifiable skill, we have to give a lot of emphasis on that. Of course, while transaction, there is a learner-centric approach should be used. They have specified the teaching learning methodologies. We are going to discuss later on about that. The didactic lecture we have to keep only less than 1/3, and more emphasis is given as small group teaching. Now, this is going to be a problem because in many institutions, I know that we don't have enough faculty members, and we have to devise how we are going to achieve this small group teaching when there is less number of faculty members are there. Self-directed learning, we have to keep the time, and this demonstrate, observe, assist and perform, that will come in the practical. The assessments also, there is a separate document on formative assessment, internal assessment and summative assessment, and we will go through that. But what is more important is that the multiple settings and multiple examiners are needed when it is a competency. And if you have heard the webinar by Dr. Tejinder, who has repeatedly he has said that whenever you are assessing the students for the CBME, the most important thing is that it means to make it reliable and valid. It has to be multiple settings and multiple examiners. It need not be that formal internal assessment examination. So expert judgment based on a qualitative subjective assessment is already there in the EdCom. We don't have the formative assessment as a foundation course or electives, but we can have as many as formative assessment when we are teaching them the subject. And the blueprint we have to make for the subject, topics versus levels. And we have to have the application oriented question. This is the one way, as I said, to bring in the integration in the assessment. And MCQ's emphasis is less, and it is not more than 20% now. In the internal assessment, 50% of the marks of the total marks are for the internal assessment, and 40% in theory and practical they have to achieve at least, but together it should be 50%, and that is one of the criteria for their eligibility to appear for the final university examination. And the second eligibility criteria is the logbook that should be appropriate for that particular phase, means for second MBBS. And the logbook guidance, that document is also there at the website. And internal assessment marks, they will not be added at the time of summative examination, but they will be having as a separate heading. And this I will see. So now that pharmacology, we will be having 200 marks for the theory, and the practicals will be 100 marks. And this I have passed criteria I already said. So in that university examination, it is mandatory to have the 50% marks in theory and practical. And the Viva marks will be considered as the practical marks. So it is practical plus Viva will be the practical marks, and theory papers, it will be theory marks. There is some time, dedicated time for sports and extracurricular activity. It is there in the foundation course, but longitudinally as well. And that also we have to take into consideration when we are planning our program. The facilitatory mechanism is a lot of programs, as I said, the faculty development programs which have been conducted by MCI. There is a nodal and regional center establishment, and the medical education unit of your institution, it's either it is a nodal or regional center, or maybe under the particular regional center or a nodal center. And we have to have our dialogues with those medical education units as well. MCI has already had the basic courses as well as advanced courses. At the time being, I don't think they have been they are on, but many of your colleagues might have undergone this, and there is a lot of strengthening has been done about the MEU. There are several documents have come on the site, and I will show you that. And there are university and institutional committees as well as these programs, support programs are there. And there are webinars like Academy of Health Professions Education, or whatever this CBME Pharmacology we are conducting at present. Number of webinars and number of programs are there. So one has to use those. Now, if you go, if you haven't visited this site, I'm telling you that if you visit this particular site, MCI India, you click on information desk, and then for colleges, and then for UG curriculum. So you will find a list of this UG curriculum volume 1, 2, 3. Volume 1 is there for the pharmacology. In addition to that, there are several documents are there. So these documents pertaining to HCOM, the one related to the assessment module, alignment and integration module, skill training module, and logbook guidelines. I request all the faculty members and the group with us to download this, and we should discuss these documents, and we should be quite aware of what is given in those documents. So please have those documents with you when you are talking about. I've seen many of you have seen this and discussed this particular program. We will be talking about that during our course. Just last things are the control mechanisms. Already there are certain controls are there that whether we are working or not, we have to upload our timetables in the month of August or something. And we have to submit the SLOs also. There are committees have been established at the college level. There will be supervision by the university, especially how the implementation is going on and the assessment plans. And there will be curricular review every 5 years through standing committee. This document on curriculum governance has not yet put on the MCI site, but it will come soon, and then we will have more insight about how these control mechanisms will be working, and what it will be telling us that who is accountable for the delivery of curriculum, who is responsible for the oversight, who will support and enable and facilitate faculty to deliver curriculum, and who will evaluate and provide necessary input that will enable the course corrections and continuous improvement. So this is different from so far what MCI was conducting for us, the inspections, and this is more or less like a hand-holding thing. But we have to work towards that, because MCI and academic cell of MCI, they have the regional center, nodal centers and universities, then the colleges, and in the colleges there are some key faculties. There will be curriculum developers and curriculum committee, and MCI has already given the norms for the curriculum committee, and all of faculty members, all of us are responsible for the implementation of this particular graduate medical regulation, and we have to give the feedback and we have to carry the program evaluation simultaneously. So there will be role distribution for every one of us, but as far as the faculty goes, that local monitoring, there is a curricular committee and medical education unit of your institution. They will be taking the main lead. And it has been said that medical education unit will be a different, it will be talking with the dean is mainly responsible, under whom there will be curriculum committee, medical education unit or department, and the head of the departments. So they should be having dialogue with each other, and this curriculum committee will be having two parts. One will be the alignment integration topic team. So see to it that this working group is there in your own institution also, which will help you. And there will be a phase-wise curricular subcommittee, so that HOD will designate for each subject one representative who will be discussing with each other. This, ultimately, they will communicate that to the curricular committee and then to the HODs, and it will go on. So this is an organogram which has been there in the curriculum governance, and it will soon get published. What we have to do at this stage, we have to think about from our own way how we can strengthen this alignment integration team topic teams by doing some exercises ourselves, as well as the phase-wise curricular subcommittee. So if we want to make some changes, and always remember that we can give our there is a feedback. So if we find that the competencies are not correct, or some we don't want that second term, we have a chance, we can always communicate. It's not that it will be listened to or things, but it is always better that collectively as a group we should give them the idea that something which is more doable, or what we think. Thank you so much.
So thank you very much, Professor Rege. It was wonderful, and it was very exhaustive, quite heavily loaded. And I particularly congratulate you on the last few slides, where you have very efficiently you have underlined and underscored the importance of reminding us what would be our expanded role at the local institution level. It's not that MCI has prescribed something and it is our duty to go to the classroom and deliver that curriculum. So it is rather, one can say that this curriculum that has been prescribed, that it is basically a curricular recommendation along with the how it can be delivered. But then in order to properly do that at our respective local level, we need to engage ourselves much more than we could have imagined. Gone are the days, okay, when we had the liberty to really talk and to really take a lecture according to our own comfort zone, comfort level, etc. So it is very prescriptive now. Of course, there is some amount of flexibility, but then they have also reminded us the expanded role of the individual medical education unit, the departmental head or the faculty, concerned department, and the concerned medical college, aligning with the role of the local university that is governing them. So it is a heavily engaging and keeping ourselves busy very much. Okay, and only good lining is that relatively younger faculty, they are taking it so seriously for the last 1 year or 2 years since this curriculum has been put in place. We are sure that we are going to deliver a really good curriculum.
Yeah, there is a lot of scope for creativity as well. And as you rightly said in the beginning, though we are aiming for to have the uniform curriculum, the competencies can be uniform, but there is a liberty based on your whatever the facilities are available at your colleges. You have to maintain that whatever the standard we decide upon. But the sky is the limit. With limited resources also, you can develop good modules also for your student to achieve those competencies.
So thank you very much. I am sure that you won't disagree to share this presentation of yours amongst all the faculty, because
Yes,
we need to also get time to absorb this. It's heavily loaded. We need to again
I know. I will send it to WhatsApp.
That's great. Only thing is, we possibly are taking more time than we thought. I would now request hand over to Professor Principalati, who will be speaking on the curriculum, this competency-based curriculum, giving possibly a little more emphasis on competencies. Professor Palati, please go ahead.
Yes. Thank you, Dr. Shantanu. And as usual, what you said has a lot of meaning. I hope all of us are listening to it. And Dr. Nirmala Rege, as usual, you have condensed such a wide aspect into such a bird's eye view of the whole MCI curriculum. So now that you have, it has been uprised, and I'm sure all the participants who are attending this CBME, they are all also very well aware from what I have seen and in the interactions that we have seen. So I'll take you through a little bit more extension on this only, but it will be in a different manner. Yes. So we are talking about the healthcare industry. One thing to note, what we are trying to do, it's not just a service industry, it is an experience. And that is why we need to have CBME curriculum, so that you have doctors that are going for this. Now, CBME curriculum is not the panacea for all the ills of medical education. This is a statement that I like to say, because definitely there will be problems and there will be things happening, but that is what it is. So the challenge here is mainly to see that we keep at the learner space. And that is one of the heart-bringing changes that are there in the curriculum that is there in the CBME. It is at the learner space. The art of medicine should be transferred to them. Medicine is a craft and it is an art, and this has to be transferred to them. And another challenge that we face is that it should be based on the outcome, and that is competency. So what is unique to CBME is the essence of professional practice. You are not thinking of them as students and loading them with the cognitive overload of knowledge, but you are preparing them as a physician in training. That's the whole change of focus that we are having now. And to get to this point, we have so many papers that have come through, from the Delphi technique and from the Lind University. They have found out for pharmacology especially, they have found out the competencies, and that's how they have come to the 40 competencies. And also here we have competencies that have been laid up. Now this is something that we keep hearing, but I'll just transgress into this transformative learning. It is not just, the student who joined in the first professional year on the first month, he doesn't just go on with a lot of knowledge, there is a transformation happening, and that is why it is a change from facts to research, analysis, and decision making. It is individual professional credentials are changed to effective competencies for the whole team. That is the basic difference in CBME. And another thing is what is happening is it is a non-critical adoption to a creative adoption measures. So that's how we implement this by transformative learning. And we have heard what is competency and competence. And I have also sent you a slide in the WhatsApp that tells you the difference between competence and competency. Now, this is direct from the MCI volume, that how to understand the document. I'm sure you all have gone through it and you're aware of it. And I feel that you're feeling the pinch how to implement. And all the words that is written in that document of MCI, we have to put it into practice. And as you have read, and as we all have understood, and those who have not read, Dr. Nirmala's little overview has told us that there is a lot left. And in this webinar course that we are in, we are going to put our heads together and find the right way to implement. And don't worry about SDL and the small group of learning, etc. So we have gone through, we have a total number of classes that have been assigned for us. The pathology and us, we have between us 80 classes. We are similar to pathology if you look at the document, and it is 80 lecture classes only that we should be having, but we should be having 138 small group learning. Now that is an area for, for us to have palpitations. How do we do that? And our institution is not taking many more. We can engage it. Just have the possibility. A great teacher is one who inspires and innovates. Friends, you and I, we have to innovate. This is the time for it, and it is happening. And we can do it. You don't have to be eureka, eureka. You don't have to say and make something vastly different. A little difference, a little change. That's what will bring out that. And you see, there is SDL classes, self-directed learning. Now, this is also another roadblock you think, but this is not a roadblock. It's a beautiful way. In fact, it is making us lesser in face-to-face and getting the students to learn. So that is the reason why this SDL 12 classes that have been scheduled to a total of, we are having the same as pathology. If you see, we are having a total of 230 classes, right? Sorry, 280. Is that it? Yeah. So this is how we are going to bring about. So today we are just touching the skirmishes. I will tell you the course that you're going through. So in this course that we're going through, we have aligned it. This is the first introductory class. And then we are going into, we'll see to the timetable. Dr. Kilnani will be having that. He has a template made already, and which he'll be sharing with us. Definitely we put our heads together, brainstorm and make things easier and better, but within this framework, which Nirmala has beautifully told us. Okay, within this framework. And how it goes, it's not necessary to, we don't have to take any tension on this part, because as we deliberate on it, we will find the way. We will find the way. In fact, the competencies that we have to get in our learners, one of them is being a good clinician. Yes, our knowledge process, as very clearly said, there's no practical competency that is a certified competency that is required. And prescription writing also is a competency that has been told. And in the communication in the prescription, it's not just enough to write a prescription. You have to tell and communicate, and you have to get the P-drug, getting to a pre-drug. So these are all the practicals that will be included. So we have a separate session on practicals. We have a separate session for assessment, and we will do it individually with the SLOs for each subject that has been laid out. But friends, we shall now concentrate only on this year, for this year. What is for the next year, that is phase 3, next phases, we shall do it at a later time when we are more conversant and we are more better with this aspects. We will go on to the pharmacology SLOs that are to be done for the later professional years. And also we must have taken classes in the first year for integrated. They would have called you, and I'm sure it would have been an awakening, and it is nice. And that is why, friends, you are not your second year students, that's all. We see them in second year and then that's the end of it. But friends, you have to teach pharmacology for the first, second, and the third and fourth. All these phases you have to teach. So we are not letting go of the students, and pharmacology is being booster doses are being given, and that is how we are coming to a total untangling and making the disarray into a proper systematic order. So that's how you're bringing about pharmacology. And as it is running late, I would like to stop for now, and I request Dr. Kilnani to take on our participants bring on our participants into this aspect. So friends, not only are we thinking about we have an aspect of lifelong learning. So in the aspect of lifelong learning, they are supposed to read articles and find out whether it is good enough or not. Are we teaching this? The onus comes on pharmacology because we are related with research, clinical trials, etc. We are teaching. So the evidence of literature, also a hierarchy of literature evidence also comes on us. So maybe this is a nice place to incorporate such things. So we have a lot of scope, and you are going to make the students that you would like to see as doctors, that you would go to. So friends, we are in the right place and we are in the right mindset, and now we will see the proper implementation of this program. We would like your comments. Yeah.
Thank you, Professor Princey. Very nicely, very briefly, you have also explained to us what is the meaning of this new curriculum and how best we can deliver that. I particularly reiterate the last part of your comments, and that is the lifelong learning. So how, as pharmacology teachers, we can make an impact on the young learners and impress upon them that this is pharmacology learning, because every year, every new there is a new medicine that will be coming up. So it's not possible to actually content teaching, which is important, but how to learn instead of what to learn. How to learn is important, and how best we can deliver that, we can impress upon these learners how to learn techniques, so that even if they leave the medical school, they will keep on learning about medicines, how best way they can learn about medicines, what are the different sources, etc. That is important. Even so long they are in the institute, after they have left the department, even then, how we can make impact on the students so long they are directly connected with us, that when they are leaving our department, when they are going to third professional, when they are appearing in the final examination, they will always remember us and come back to us. So it is, the curriculum is giving us an opportunity to go beyond the traditional, until today, the practice of getting too much of obsessed with collective obsession of the teachers and students about passing the subject. It is much beyond that. It is helping them to develop the skill, the competencies, and how best we can do that. The curriculum is offering us this opportunity. Let us grab this opportunity collectively. With this, I hand over to Professor Kilnani, who also will be making a brief presentation, probably, if he wishes. Otherwise, he will be actually coordinating interaction of all of you who want to get engaged into active sharing your inputs, your comments and questions, which will be now discussed. So Professor Kilnani, please hand over to you.
Good evening, everyone.
Good evening,
Am I audible?
Yes, sir.
Yes, you are.
Dear friends, after these 3 sessions, now we are aware and realize the importance of CBME and particularly pharmacology. And we must also have understood the challenges ahead for implementation of this program. Now, the most important would be how teaching units and teaching modules are to be prepared. And I think in subsequent sessions and days, it will be easier because of the sensitization of today's sessions. Now, there are few things which I want to share, and then I'll invite the participants for question. One is this activity. Hello.
Hello, sir. Please click on the share screen button. Show my screen button on your screen.
Which okay. Is it okay?
Yes, sir. Now start PowerPoint. PowerPoint is not visible. We can see your screen. Your PowerPoint presentation.
I don't have any PowerPoint. It is only because this was an interactive session. I don't have any PowerPoint, sir. This time I don't have.
Okay. Please go ahead.
CBME work has been done in at least 2 units. The document is already there. And then Rahul Gandhi University is also making for even pharmacology. Some documents are prepared by individual researchers also. For example, microbiology document is available, and to some extent, Dr. Badial, some of us are also publishing smaller publications in smaller journals also. So participants must be aware of this activity, and wherever the information available must be read and imbibed. This is one thing. And the second thing is there are 4 important components which we all must understand. One is understanding the document itself. Second is extent of the second is driving of the SLOs, methodologies, and tools. And the third is extent of integration, and fourth is assessment. Each will be discussed in further sessions. Today, I will like to invite participants to ask questions and share their views, if there is any question.
Yes. Please raise your hands, or yes, there are some questions, sir.
Yes.
Dr. Dhanya Palapalli, she has okay, Dr. Surinder both first. Yes, Dr. Surinder.
Yes, sir. So, as per previous curriculum, that was a 3-hour session for the pharmacology, pathology, and micro 250 hours, and forensic was the 100 hours. But right now, that time slot has been reduced for 1 year, 12 months. So, how much hours that we will utilize for the didactic lecture? How much hours for the integrated sessions? So, that distribution has been given by MCI?
Yes.
And I want clarification.
Okay, I will reply and also request my colleagues to reply. Let me reply first. Now, the curriculum hours assigned by the MCI are sufficient. Please, it should be made clear that hours assigned for pharmacology curriculum are sufficient to cover the competencies given in the document. This should be made clear. So total hours 230. Okay? Total hours are 230. They are divisible into the different components. And these different components are in front of me, and I would like to circulate also. For example, lectures will be 80. Non-lectures, something like non-lectures would be 150, which can be divisible as small group discussions, including seminars, tutorials, skill sessions. Now, practical is disappeared. It is only skill. We must remember that. There is no theory. It is only lectures. Even K component of skills can be theory only. So this should also be clear. And finally, self-directed learning. If you divide these 150 non-lecture hours, they can be divided to cover the entire topics. And actually, I have done this exercise, and I found even few hours are left for revision. So this should not be in anybody's mind that the coverage is insufficient. That will always be there.
So, sir, this one, these details, distribution of that whole hours, it is given in the MCI website. I will download.
Yes,
Or
yes.
you are going to provide.
No, sir, no.
Okay.
Actually, the division has to be made at the institutional university level, particularly small group discussion, tutorial, that part, or practicals, because they will have practicals. I will tell you here, there are, in a skill component, there are 4 certifiable competencies, which we have to repeatedly give students to do it. Therefore, these can be broken into hours, and it is possible to break them into hours. And what actually, one example I'll give you, it's not that everybody should do that. For example, small group discussions can be around 20, tutorials can be around 20, and skill practicals is completed into 100 hours, including 4 certifiable competencies, means at least 3 to 5 times repeated. And this will cover 150 hours. That will exclude lecture hours 80. Maybe next some session, one of us will be speak on it also. But there should not be any anxiety or feeling that we cannot cover the subject.
Yes, sir. Because sir, right now, as per the previous curriculum, total didactic lecture for the general pharmacology, it was taking near about the 15 to 16 hours. So, okay.
There are only 64 competencies, and there are only 5 topics or 4 or 5 topics. So topic doesn't mean that topics means theory total. This is topic 1. So something like that. Now, and these 64 competencies can be covered in 118 hours. That includes lecture 80 plus no lecture, something like 40.
Okay.
So this is clear, and we'll be discussing it. We will seek your opinions also.
Yes.
Okay, sir.
Dr. Veeravali, as Dr. Kilnani said, no worries. Well, you and I, we are all going to break through all this individually. We are going through each SLOs, and we are going through each competency and developing the SLO, and from that, how we will divide it. So you don't have to worry. Forensic extra hours are there for all the 3 subjects, and there is enough time. No anxiety over this issue at all.
Correct.
Okay.
So let me reiterate that in fact traditionally we have an extra over obsession with lectures. Okay, that gradually we have to change our mindset and give less importance to only didactic lectures. And if we keep our attention to the competencies that we are supposed to actually focus on, in that case, lectures, as Dr. Kilnani has said, that 80 hours for lecture, that should be really enough. Okay, and then Dr. Kilnani also has mentioned that 20 small group discussion and 20 hours, of course, 20 tutorials, it makes 40. So 80 plus 40 makes 120, and for skills training, he has kept aside 100 hours. So 120 and 100 hours, 220. So still we have a few hours left as per the 1 year requirement and available hours to us. So really, I reiterate with Dr. Princey and Dr. Kilnani that we need not worry, and in coming discussion also, in the coming sessions, we can have these dissected out more precisely and more categorically, so that our anxieties and worries can be minimized. Thank you.
So, thank you, sir.
Dr. Dhanya Palapalai.
Yes.
Good evening, sir. Actually, thank you, madam and sirs. I wanted to clarify one thing. Both the resource persons have told that there is no certifiable skills in pharmacology. However, in the MCY document, I find that PH 3.5, that is to prepare and explain a list of P drugs for a case or condition. It is a certifiable skill which requires 3 performances from the part of the student. So, may I know why it is not certifiable?
Can I answer that? If
Yes.
you go to the assessment document, you will find a list of certifiable skills. In that, pharmacology doesn't feature. Whatever is mentioned as P, that they have to perform, as Dr. Kilnani rightly said, that there is a number which is given, either 3 times or 5 times you have to, they have to repeat it. If there is a feedback is poor, you have to give them more practice, and that should be entered in their logbook. So that way,
Okay, ma'am.
it is, you have to certify it at your level, but at the end, there is a list of certifiable skills which have been given by MCI in the assessment document. There the pharmacology doesn't feature. That's why I said there is
Okay,
no
ma'am.
certifiable skill.
May I say
Okay,
something?
thank you.
May I give my inputs here?
Actually, in the document, in the volume 1, 4 competencies in the skill, so probably topic 2 or 3, they are certifiable. And what I personally feel, even for example, ORS is such an important exercise, it should also be certifiable. So it is not that only 4 should be certifiable. I would suggest that 5th should also be certifiable, because this is a very important, that 90%, more than 90% of the students or 100% of students should be proficient to use the ORS effectively.
Can I make a comment here? Regarding
Yes,
the
please.
regarding the certifiable skill, now what certificate you are referring to? Certificate means certificate to practice medicine, which is given by again the MCI based on what? Based on a successful completion of the final examination. And in order to get the ticket to sit for the final examination is you have completed the other professional examinations. So truly speaking, if you split the certifiability, so that is again ingrained in the completion of first professional, completion of second professional, completion of then final professional. So in each of the professional terminal examination, university examination, whatever skills you are assessing, practically you are also contributing to the certifiable skill. Now they might have mentioned certain degree of, when somebody is coming out as a basic doctor, what are the competencies and skills that must be given enough emphasis on so that they can be certified. And that's why that the number of skills have been reduced. But that doesn't mean that each time when a person is coming for appearing in pharmacology exam or in pathology exam, whatever you are assessing, that is also indirectly contributing to the final certificate. Okay, that's my impression and understanding into it.
Yes, Dr. Shantanu, I agree with you.
Yeah, go ahead, please. Any other comment, question?
Anuradha. Dr. Anuradha Dushchal. Please
Hello.
speak.
Good evening, sir.
Good evening.
At the onset, I would like to say that very nice presentation, madam and sir. Very comprehensive overview. I just have to say it's just just what I had felt, what I feel about our subject particularly. It is the undergraduate who comes to us is a 12th pass candidate, and so we have to impart information regarding drugs, and they are like very naive to the concept of pharmacology. So the problem that I was facing, because I've been put into designing this thing, and that was the sole idea of my joining this also, as I earlier said. So we can't do away with didactic teaching. So many of the topics we'll have to take in the didactic mode. And rightly said, for that the lecture hours would be sufficient. And rightly that it is very challenging for us because the skill section is negligible, and there are AP sessions, and there are small group discussions also, which always have to, like, we'll be working on it as has been said. But personally, I think we can't go away with didactic teaching. So first-hand information upon drugs, their indication, adverse effects, and therapeutic uses we have to give. And then later on, this is my thinking, that later on maybe we can discuss other aspects. Say, for example, if we are talking tuberculosis, so we give them didactic lecture, maybe give them, and I want comments on this from all the seniors also, that if we teach them anti-tubercular drugs, then later maybe we can take up in a group discussion or in a tutorial MDR or XDR, because we are short of time also. As compared to 1.5 years, now we have effectively 11 months in which we have to do the assessment also. There will be 2 terminals also. There will be a lot of holidays also. So I think, please correct me if I am wrong somewhere.
Yeah, Madam Anuradha, may I speak up?
Yes,
I would
please,
just like to say the example of tuberculosis has been given in the MCI book itself. Okay.
yes, ma'am.
And this tuberculosis, it will go in integrated. You can do with microbiology. So the whole idea about CBME is important things you have to repeat,
Okay,
so
ma'am.
that it is ingrained. So from a lecture and to a small group teaching to an integrated teaching with the other, you are reinforcing what is needed in your student. And this is done better in the CBME way than we would have done otherwise. That is the beauty. Now, in general pharmacology, if you see, one of the first competency there is to define and understand the principles of biopharmaceutics. Why take a lecture for biopharmaceutics? You can have a small group learning or a practical class where you show all the various devices, metered dose haler, the transdermal patch, etc. And that is a beautiful lasting learning. Then having it in a lecture class and showing it in a video, you would show pictures, I'm sure, but that would be, so don't take it again in a lecture class. Do it as this. So that way you're staggering the chapters and you're reducing boredom. Otherwise you may have didactic class, but your student is sleeping, not having any intake of what you're saying. So that is the difference that is with CBME, and it is possible. It is possible, and you will do it very well.
Yeah, please go ahead, Dr. Kilnani.
So far as lectures are concerned, they will have to be there, and MCA also says 80 lectures can be taken. Now, of these 80 lectures, they can be full class. You can even divide this lecture as a small group discussions during that 1 hour also. Now, it is up to the institution or university to decide, depending on the nature of the topic we are covering. Now, what I found is that general pharmacology could be covered in, say, we used to cover into 3 months. Now it is not like that. It is only 16 hours. Where is the need of teaching student details of cytochrome oxidase deep into the mechanism of action of drug, which there will be very little application during his later years. Therefore, these can be abbreviated and more clinically oriented and patient-related and relevant information should be given to the patient.
Thank you, sir.
Thank you. No,
Thank you, ma'am.
I would say, Dr. Anuradha, that I fully respect your perception and your understanding and your concern that lecture must be there. But that is how this is the time when gradually we should also change our mindset. The problem is actually this is the manner, traditional way we have been taught the subject during our student days, with extra emphasis on lecture, over emphasis on lecture. I know of departments, medical colleges where pharmacology was taught in 150 hours of lecture. Even then there was anxiety that it has not been covered, and there are educationists, they say that it's better not to uncover them so that students can discover. That by this they mean actually, because it is a student oriented learning that is being given more emphasis on, so lecture is not just to deliver the content or the information, because you just cannot cover all the information in these 20 lectures or even 160 lectures. But then you are sensitizing the students what they themselves should learn by themselves, and for that I think you can earlier there was a concept of MUN, that is must learn, useful to learn and nice to learn. Now that has been converted into two categories: core learning and advanced learning, probably. So what is the bare minimum things that they must learn, and how we can facilitate their learning? And for that we can use, I fully agree with Professor Kilnani, that the lecture hour can be fully utilized for innovating how best we can use this hour for there could be different variants of lecture also. It cannot be just a monologue. A teacher will come in the class and keep on saying on a given topic, and that's what only they need to learn and take notes and then go to the exam and just reproduce that. So the overall emphasis and the direction is changing. We have to adapt ourselves to that. Thank you.
Thank you, sir.
So Professor Bedi, also keep your watch on your time, how much time we can continue this.
Yes, just Dr. Chandrasekhar.
Yes, please.
Almost but nearing the end.
Hello. Hello.
Yes, please carry on. Please.
Yes.
Three things I want to clarify all the things here. First thing is what the Nirmala madam has said, but we should need the certificate. The thing is, we should create the awareness for the students how to write the prescription writing.
Absolutely.
Because I've seen so many students, if their prescription writing is just like writing like a short essay, for that we should certify whether they know to write the prescription or not. This is regarding the clinical pharmacology, specifically in the prescription. Next, coming to the how to give this intramuscular injection, intramuscular, intravenous. Whether pharmacology will teach or general medicine will teach this, how to give the intramuscular administration. Because we had the debate, general medicine people that are telling they are going to teach how to give the intramuscular injection. Then pharmacology, what to tell about the route of administration. Whether pharmacology should teach or general medicine will teach. This is regarding the route of administration. Nirmala madam told that various routes of administration like transdermal patch and all. The dermatology will teach the transdermal patch. But as a pharmacology, what should we teach for them? Specifically, certain things we not clarified that one.
Okay.
Hello.
Let me reply this first.
Yeah, please.
Hello.
Dear doctor, if you look at the document, you will find that there are at least 3 competencies regarding prescription. One is correct prescription writing, pH 1.10. Then there is another one which is communication with the patient, pH 3.1. And third is 3.2, and that is prescription audit. Apart from e-drug and everything. Now, of these 3, of these 4, 3 are certifiable. So I think MCA is given quite good importance to the prescription writing.
That's correct, sir. Regarding these practicals, so in that practical classes, specific route of administration, what we should teach in the practicals. If you tell that routes of administration intramuscular, we will be teaching in the manipens. But
manipens is skill lab or the formulations which are available. What we do without skill lab is formulations which are available currently in the market, intramuscular injection, that oral tablets, different type of doses, formulations to prolong drug actions, intravenous, what are the characteristics of high volume, then all these can be kept in the museum, and during training in the practicals it can be shown and discussed.
In the last of basic simulation learning, in that Ludhiana that told we can teach only the intramuscular intravenous. So in the CBME, whether we should target only this intramuscular intravenous or we can teach other also.
You can do other
Dr.
also.
Chandrasekhar, may I give a clarity in this? All this, the whole basis of competency-based medical education is on progression of your competency. So medicine will teach, but before that, in second professional year, we are teaching them the theoretical aspect and also showing it on a simulation. Okay, so you have to teach all that you have to teach, and it will be finalized and done by the medicine. So we are progression of competency. So you and I have a role to teach how to take IM, how to take IV, how to do an intradermal injection. All these have to be told. What are the sites? What are the alternate sites? What is the angulation? How to do it? Has to be told. It is like knows how. They are not performing, but they are showing knows how and shows on a simulation. Yes.
So there is a lot of background noise. Can you please mute yourselves if you
Yes.
Yes, Dr. Sanjay, any other?
There are two competencies.
Yes,
Can be, I
No, I don't see any more hands.
Some of the use of the dosage forms.
Okay then. We can close up.
And
So I think, sorry. Yes, we can end it now. Thank you. I thank the honorable resource persons, Dr. Shantanu, Dr. Princey, Dr. Khilnani, Ma'am Rege, and thank you all the participants. We can end it now.
Thank you very much, Professor Bedi.
Good
Thank
night.
you all.
Thanks all co-faculty.
Thank you, sir. Thank you all. Thank you, ma'am. Thank you all participants.
Thank you.